Hi, this is Dr. Suresh Ramalingam, Professor of Hematology and Medical Oncology at the Winship Cancer Institute of Emory University in Atlanta, Georgia. This paper that we just published in the New England Journal reports on a phase 3 clinical trial of osimertinib versus standard EGFR inhibition for patients with EGFR mutated advanced stage non-small cell lung cancer. Osimertinib belongs to a new class of EGFR inhibitors, which we refer to as mutation-specific inhibitors. So this drug inhibits the EGFR exon 19 and 21 mutations, and it also inhibits the T790M mutation, which is a resistance mutation. When we look at the field of EGFR inhibitors in lung cancer, we have two drugs in the first generation called erlotinib and gefitinib that are already in clinical use in the US. Afatinib is a second generation drug that's also available for clinical use. These drugs have a higher inhibitory effect on wild type receptors compared to osimertinib, so they tend to have more skin and gastrointestinal toxicities in general. What is different about osimertinib from the other drugs is that it not only blocks EGFR activating mutations in exon 19 and 21, but it also blocks the important resistance mutation, T790M. When we treat patients with erlotinib or gefitinib, even though they do well, after a while they develop resistance. And in nearly 50 to 60% of these patients, resistance is mediated by the T790M mutation. So what giving osimertinib provides you with is ability to not only block the mutation that the patient has, but also shut off an important resistance pathway that the tumors look to grow and outdo the therapeutic potential of the drugs that you're using to treat with. Lung cancer is the leading cause of deaths among all cancers in the United States. What's been exciting in the field of lung cancer in the past few years is we have been able to understand different subtypes of lung cancer based on genomic characteristics. So osimertinib is a drug that's directly relevant to patients with EGFR mutations. And EGFR mutations are seen in 15 to 20% of patients with lung adenocarcinoma. We don't see EGFR mutations of exon 19 and 21 in other diseases commonly, and that's why lung cancer is of prime interest to this drug. EGFR targeted drugs were developed almost 15-16 years ago and were initially used for all lung cancer patients regardless of whether they had the mutation or not. In the year 2004, it was clear that these drugs work very well for patients whose tumors has the mutation, but not as well for patients who don't have the mutation. So the mutation has become the biomarker that you use to select treatment with an EGFR inhibitor. The mutations are tested in the tumor specimen. Now you can actually also test them in the blood by looking for cell-free DNA. And the mutations that we commonly see are located in exons 19 or 21 of the EGFR protein. And when somebody has these mutations, they have a very high likelihood of clinically benefiting from an EGFR tyrosine kinase inhibitor, such as osimertinib. So it is now standard of care for a patient with newly diagnosed lung adenocarcinoma to be tested for certain mutations, including EGFR. This was a phase 3 study in the frontline setting for EGFR mutated patients. We compared osimertinib 80 milligrams a day to standard of care TKI, which could either be erlotinib or gefitinib, depending on what the participating sites wanted to treat their patients with. 556 patients were enrolled, one-to-one randomization, and the primary endpoint was progression-free survival. What we reported is that the median progression-free survival was 18.9 months with osimertinib compared to 10.2 months with standard of care, and the hazard ratio was 0.46, and the results were highly statistically significant. The survival results are immature. We only have 25% maturity of the data, but the hazard ratio appears to favor osimertinib at 0.63, though the p-value is not statistically significant at this point. We will report the full survival results once they are mature. What separates osimertinib from the first and second generation drugs is that it can block the T790 pathway in addition to the native EGFR mutations. Now, given our knowledge that nearly 50 to 60% of the patients who get a first or second generation drug eventually develop acquired resistance, and in many cases through T790, we're now able to use osimertinib and shut off that resistance pathway. We think that that has important implications on the positive results that we've seen from the FLORA study that were reported in the New England Journal. In addition, osimertinib also seems to act better in the brain because we've seen patients have lower incidence of progression in the brain with osimertinib compared to standard tyrosine kinase inhibitors. Another advantage with osimertinib is also the fact that the side effect profile seems to be better. So overall, the efficacy of osimertinib in the frontline setting result from strong EGFR blockade, shutting off an escape mechanism, activity in the brain, and a favorable tolerability profile. Stage 4 lung cancer is where the EGFR inhibitors are now used for standard practice. In stage 4 lung cancer, while long-term survival is possible, we're still not in a position to cure these patients. However, the good news is we are testing drugs such as osimertinib in even earlier stages of the disease before the cancer has metastasized to see if we can actually use these drugs to achieve cures in patients. Those are being studied in ongoing clinical trials. So for the time being, in the advanced stage disease patients, drugs such as osimertinib provide us with robust response rates, improved significantly longer progression-free survivals over standard therapies, and potentially favorable improvements to their survival. And we can build on these in the next steps through ongoing clinical trials to extend the potential of these drugs to cure patients.